Now we have Dr. Krishna Prasad, who will be talking to us about Phaco trabeculectomy, the tips and the tricks.
So good morning, and I thank the AIOCMT3 for the opportunity. So when you have a coexisting problem of cataract and glaucoma, which needs a surgical management, so that's the time when you think of a combined procedure. So it's always the industry always wanted to, they were always worried about us that because we never needed any gadget to do a glaucoma surgery. Most often the trabeculectomy required nothing except the surgical skills. So finally they have managed to, put in some gadgets like we have now KDB, we have eye stent and all that. So that's the changing scene now. So we are now trying to change the whole scene of a combined surgery with a lot of gadgets. In some select cases, they definitely replace Phaco trabeculectomy. Having said that, the coexisting thing is normally when you have a visually significant cataract and the glaucoma is not well controlled, and this is an opportunity to probably tackle both the things for very obvious social logistic advantages. So this is the usual postgraduate narration that we say. When you have glaucoma is well controlled with medication, you have a visually significant cataract, do only cataract surgery and control the glaucoma with medication. This is what a postgraduate should answer actually. And when you have problems with medication, IOP not controlled, and you have a cataract, then you do a combined surgery, which obviously as practitioners we take it with a pinch of salt. So we normally do not prefer an SICS because it consumes a lot of conjunctiva, so further glaucoma surgeries would be difficult. So Phaco trabeculectomy, that way a clear corneal incision, is a definite blessing for a patient who requires glaucoma management for a long time. But when you do only cataract surgery, you may have a post-op IOP spikes. You should be wary of that. So basically when you have this situation, we also, since cataract surgery is not very difficult for us nowadays, so we always tend to kind of assess the cataract in a totally different perspective. How much cataract is significant? The patient is aged, still the lens is not really opaque, there's a nuclear sclerosis. After your glaucoma surgery alone for your IOP, the cataract may progress. So that is the indication probably where we kind of rather prepone the cataract surgery, and a combined surgery would be definitely better in that situation. The technique is very critical. You may have a single site, you can open up the conjunctiva, do a scleral flap and go under the scleral flap and do a cataract surgery and completely complete the trabeculectomy. Or you can have, since it's a clear corneal procedure, we have an advantage of doing our glaucoma site anywhere and have a clear corneal entry, superotemporal or temporal entry. And let me start with a procedure. This is where we do a single site, like you do a typical peritomy and use mitomycin, and you have a flap, whether triangular or rectangular. So once you do the flap, so under the flap you enter the in a clear corneal manner. You basically make sure that you have enough corneal lip. You're not really entering at the limbus, then it will cause a lot of leak and that would actually affect it. So you go more anteriorly and enter. So in that situation, it would be, it will still act like a tribe. Once the surgery is done, it is like any other eye glaucoma surgery. So you complete your Phaco. So once you complete your Phaco, you put the IOL, then you go back and do your trabeculectomy and complete it. So you do a PI, put sutures. Here I'm doing an adjustable suture. Here are two fixed sutures and an adjustable suture. So that's how with the same site you can complete both. You don't have to really move in. This would actually work well for left eyes for right-handed surgeons because you don't have to really move to make a temporal entry. Superotemporally you can complete both trap as well as thing. At the same time you can also have a two-side procedure. So I've already made a flap superotemporally. Now I'm moving to my temporal clear corneal entry and completing the Phaco emulsification as we normally do, and you can complete your trab come back to the trap site and complete it. So, well, everything else is same as in a routine trabeculectomy. You can use different types of suturing techniques, your mitomycin application, everything tends to be the same, and whatever modifications that you want to actually apply during the surgery, because there's always a tendency for overfiltration in the beginning, so we tend to make sure that it doesn't overfilter, especially in a pseudophakic patient. If there is no overfiltration, then the lens can really come forward and touch the cornea or come very close, which may be not cornea friendly. So we tend to be slightly, so you need to have some parameter as the healing kicks in by between 10 to 20 days. That is the period where most of the trap starts failing. So you try to modulate the wound healing at that time, either pharmacologically, you giving injections or trying to nudge the sutures or trying to modify the healing in any form, so that you don't have the underfiltration after the healing starts. And this is a very unusual situation. I mean, it's not a very unusual situation. You have silicone oil. Normally for a VR surgery, there's a silicone oil in situ, and the patient develops high IOP. You need to probably, they also have developed a cataract sometimes. So these are all the silicone oil globules that you see in the anterior chamber, and you can, this is one situation where it's actually, the phaco is difficult because of those the shining, the posterior hyaloid phase, because there's a vitreous, not only a vitrectomized eye, you also have those silicone oil giving you very unusual reflexes from the back, which is actually sometimes quite difficult to manage. So if you already have a previous filter, then you make sure that your cataract surgery should not really alter the filtration. You should prevent a damage by at least blocking the entry of these lens components into the filter. And most of them actually are difficult because of the other problems like small pupil and posterior synechia. So finally, most of these patients will have non-dilating pupils, posterior synechia, they have a hardened big nucleus, especially with PXF glaucoma, floppy iris, especially in ACG cases. Pigment dispersion is quite known, and if you have a PXF, you have a hell lot of other problems like this zonulopathy and other problems, and sometimes poor endothelium and exaggerated post-op reaction. And most importantly, you have the, it is not like a routine cataract surgery, so you need to, basically explain the patient before surgery that only the cataract component is something that they should be actually optimistic about, not the vision loss due to glaucoma. So this clear communication really solves a lot of heartburn and saves the trouble for the, and it's very important to make them understand that we are doing two surgeries, and whatever vision loss due to cataract will only be recovered, not the others. Thank you so much.
That was very good videos you showed. So I just wanted to ask, for the sake of, I don't know how many residents are sitting in the audience. Do you take any special precautions while working? Like this was a case of combined cataract, and I think you're talking about phaco trap, but just a question which is not exactly the, especially when you're operating on a patient with already a pre-existing bleb. So
Yeah. See, that's I didn't want to really cover because it's a little offbeat.
But I'm just asking a question for the sake of the residents there.
It's very important. See, we do get such situations like there's already a previous filter, which is sometimes, sometimes working, not working. If it is really not working, then it doesn't really matter. If the bleb is working, the IOPs are controlled, if the, then it is important that you don't really make that function deteriorate. And it is found that if you don't take care, many of these blebs actually fail. How? What is the mechanism that has been envisaged is, you have this fine lens material when you are emulsifying, they all get into the filter, they go into the bleb area, and all, as you know, this lens matter is immunogenic, it incites inflammation. So you have some kind of a very low grade inflammation in the bleb, which promotes healing, and the bleb can close. So this is what the filter, whatever that, so those channels that have been formed can actually close because of the inflammation. So this is one very important thing that we have to keep it in mind. So when you're actually doing, normally what I do is either a Helon GV or Viscoat, I try to go to the filter area, to the stoma, there I really put it. I make sure that I rather close that the filter, that is the internal stoma of the trabeculectomy, and then continue the surgery. Of course, if the surgery is a short period, if you're taking care, that viscoelastic normally prevents, or we hope that it prevents the entry of this lens matter into the thing. So that is one very important, and also your incision. If you already have a filter, obviously you need to do clear corneal ideally in a phaco emulsification and avoid things like SICS. And if you are doing another surgery, another trabeculectomy in a previous filter, then obviously your whole game plan changes. You need to shift to another place and do it. So two site would actually help. I would normally do two site, because a clear corneal phaco is something which doesn't really change the planning for any glaucoma surgery. You have the entire, the limbus available for future surgeries.
So have you had cases like this of single site phaco trap after a failed trap?
Yeah. See, that is another option. You have already had, you don't really have much of limbus, so obviously, no, but having said that, it is, whether you do under the same flap or do a clear corneal, it doesn't really matter. Basically, it's about your right-handedness or left-handedness in the right eye or left eye. So if I am planning to do a superotemporal trap and a temporal phaco in a left eye, then I have to really move towards the patient and all those logistics and ergonomics. So I would rather do a single site. But both of them work the same. We had a dissertation on that also, but we have not found much difference in the results.
You talked about adjustable suture in the presentation. So you prefer adjustable suture over releasable suture?
No, I am not a big fan of releasable suture. Normally I do adjustable. Actually, I do most of my, this year I showed 2 fixed and 1 adjustable. Now I put all adjustable. So basically, if in the immediate post-op, that usually after 10 days, we get a chance to see them, we normally adjust it. I mean, there are different ways of doing it. You can use a particular forceps, or you can even actually take a Johnson bud and rub on the thing, because they're all, they are not fixed sutures, so they slightly open up, and if you have more sutures, it's more safer and you have a more option to modulate. Releasable, again, they come out and sometimes they get cut, and they're not very predictable sometimes, and they have to really pull it very early in post-op period, which doesn't make sense. And wherever I have put adjustable suture, where the IOP has really, has behaved very well. And wherever I have not put it, the things go haywire. So that is the Murphy's law sometimes.
So maybe adjustable versus releasable, because you said you're a fan of adjustables.
Somehow in my hands, releasable has not worked very well, and the kind of post-op problems. So and maybe I have met some success with adjustable, which is more simpler and easier. So I have been basically stuck to adjustable. I mean, nothing against releasable. I still do it for the sake of novelty to show postgraduates.
So I would say that has worked as a good luck charm for you, the adjustable sutures. Some of us like releasable suture, but I think both work equally good, whatever surgeon, a particular surgeon is comfortable with. Of course, you have to be careful that the patient is available for follow-up when you're putting releasable, as Dr. KP rightly mentioned, that if the patient is lost to follow-up, they can come out, chances of infection. So those are the things we need to keep in mind, but I would say both the...
Yeah, see, releasable is definitely a better chance if you're doing a high-stake case. It's a high-risk case, and if you can see them more often, if the patient can come to you repeatedly, releasable is the way to go. But our set of patients sometimes is not possible. So we have to modify many things as per a lot of patient factors also, on the place you work and the logistics.
Right, and also the technique for that matter, like keeping the tip in the corneal tunnel. I'm sure all of you are aware of that. But thank you very much, Dr. KP, because I would say that trap is still the most commonly performed surgery, and all of us have to deal with very difficult situations in advanced glaucoma, failed traps, post-silicon oil. So this is one technique and tips that we need to learn if we have to be a glaucoma surgeon and bail out difficult situations.
That's why I alluded to MIGS in the beginning, that the industry is now happy that they have insinuated some gadgets so that we are consumable now, slave of consumables. Till now, we were completely free. We had freedom of, not caring for any company, and we could still get down our prices of surgery, and we could even do a surgery for free, but not anymore now.
Yeah, But I would say those are not very skillful procedures. Those are much simpler to
Exactly.
perform. Trab is still a most challenging
And a very
situation.
limited indication. You
Yeah.
can't do it on every case.
Yes.
And if you really want to bring down a very high pressure, it doesn't really work that way. And we have really mastered trabeculectomy, I should say, so that we can definitely teach our youngsters to do a good trabeculectomy. Anyway, these gadgets will remain. Thank you.
Thank you.